sponsored meeting, and this just will be a brief, again, lipid management post-acute coronary syndrome patients. That's my disclosure. And really, the only objective for this is how to manage patient with acute coronary syndrome from lipid point of view. We all know that cardiovascular disease is a leading risk factor, leading cause of death in the world, and even the COVID time. We all know that 18 millions and even more compared to the COVID itself. And we know if we focus on multiple risk factors, which we discussed by our great speakers today about how to prevent, there are many things. But if you focus on lipids today, just for this sake, and you know that the randomized clinical trial, genetics, observation, everything point to that LDL, it's the causal risk factor for and the guidelines. That's the problem, yeah? The guidelines every time is changing. And now we are in 2021 or 22, and the guidelines tell us, to go lower, the lower the better. But how to achieve that is not easy. As doctor, all of us say, awareness is there, management is there, control is not there. The problem is what is it? Is it patient? Is it physician? Is it, the system? What is it? We don't know. So this is the fundamental. We should know this. I mean, LDL, it's absolute or relative similar if you use the medication to reduce the outcome. And to do that is you focus on lipid lowering, not just medication, rather just statin itself. And based on risk stratification, which nicely showed us, and the the new guidelines tell us who are the high-risk patients, very high-risk patient, and extensively high-risk patients. Focusing on this, patient with acute coronary syndrome, these could be very high risk or extremely high risk. And here you don't waste time. We used to just go like sequential, statin, combination. You should not do that. I'll tell you why. Some data from this part of the world, and you're already seen by many doctors, and tells you you should have it in your office. You should remind yourself about it. And of course, this is 2019. And you can see there it says 2B and B. That's changed, I think, with the new data we have now. I think should upgrade that, because really we are not doing good job if we go sequential, because we are still lots of patients will not be treated. So this not right. I think this high intensity statin, then high intensity ezetimibe, then go PCSK. I don't think this should be the way. We know if you do everything together, then you most likely to reach the target in terms of the control of the LDL. And this is we're speaking here about established cardiovascular disease. Then I speak about acute coronary syndrome. In established coronary artery disease, we know these are the patients where we can consider PCSK9, and high intensity lipid lowering. Patients who already had vascular problem and more than 65 diabetic smoking, you should not waste time, and you should really target that. I just give you just a comparison what happened in the past. TNT, remember, high intensity statin compared to low intensity, the benefit of high intensity. But here the PCSK9, if you use the PCSK9 compared to high intensity, with a statin you reach that in 6 years. And how much reduction LDL? 1.8. If you use PCSK9 in 3 years, and you reach what? 0.78, and in shorter time and in a more effective way. And if you use compared to ezetimibe, using it with a statin, it takes you about how many years? 7 years to reach there. But if you use the PCSK9, it takes you only 3 years, and comparative risk is 6.4 compared to 20. So really, you should not waste time in acute coronary syndrome or established cardiovascular disease. So these are just to tell you, every time the guidelines change, we have a problem of reaching the goal. So if you use the guidelines 2016, only 39 are reaching the target. If you use 2019, even lower, 18. So really, it's not easy if the goal is changing all the time. But that's the life. So 75 of patients of established cardiovascular disease not reaching their target. So that means only third reaching. And the same apply to our region. And not only that, the patients who remain on the medication with the statin, as times go, is lower and lower. Just look at the effect of the PCSK9. If it's used, how soon you will get to the target. Here tells you the answer. The LDL level decreased by 58 within the month of evolocumab initiation. And most of the patients reach their target, you see, and even 1.8 or 1.4 significantly within few months if you use evolocumab, compare if you use a statin, which take you long time. In Fourier sub-analysis, here I want you to look at the patient's, safety, of course, you all know about safety is being studied. We should not have concern about it. You see this flat, that tells you really nothing there. The cataract, cancer, everything, hemorrhage is not there. So you should not be concerned. So what's the mechanistic? Is it only LDL or something else happening? I think something else happening. You look at this. If you are reaching the 1.4, you are actually, kind of stopping plaque progression. And if you go even lower, you lower the plaque. So basically, somebody with a plaque at their arteries, coronary arteries, if you use these high-intensity lipid lowering, you will actually regress that, which is great news. And how that happened? Look at the OCT, lipid arc, fibrous cap, microchannel, macrophages, cholesterol crystal. All these are, kind of objective and not just theory. It's been seen and been done. So what a great news for the patients who have got vulnerable, and you can do that. And this is our patient here. We're speaking about the myocardial infarction. This is the time where you need to intervene, and you have to be aggressive as much as possible, because acute coronary syndrome patients are we know 14 patients will not reach. They die before they reach the hospital. And the problem with that, they are the majority of, if you look at of the cardiovascular disease death, is majority due to acute coronary syndrome. And the recurrent of these patients, I'm sure you've seen it. They come back to you. Many reasons for it, but lipid is the main reason. So nearly 1 in 5 hospitalization, readmission 18%, cost and burden on you and your system and family and everyone. So if we can kind of hold that and prevent this in future, I think it will be great. So first event will be nicely prevented, and to a great extent, by using evolocumab. And just look at this. I want you just to look at this. This is very bad, for bad news in our region. 16% compared to 18%. Middle East compared to the rest of the world reaching their goal of acute coronary syndrome, which is bad news. So combination of a statin with ezetimibe, it will not reach you to the guideline recommended LDL. I've seen it, and you've seen it, especially the way it's done now, sequential. Do statin, high dose, then go to many of them not be done. I'm going to show you the study from this region. This is our study. It's been published. This is only Emiratis. They can afford the medication. They can't afford anything because this is free. Okay. Despite of that, look at their LDL when they had these are the demographic. Look at the LDL when they had MI. It's 84, but not very high. But what you want to do, you want to reduce that more than 50%, or as low as 1. Can you do that? But look at what happened after 6 months. What happened? Just nearly, look, 84 went to 7.8, 78. Why is that? What's happening? This is at all Sahha, all Abu Dhabi, not one center, all Sahha Abu Dhabi. Why this happening? Who to blame? Your patients, the doctors, the system, what? I'm not talking about Dr. Walid or Dr. Muhammad Asmi or so. I know you are Muhammad Salah, you are great, but I'm talking about everyone. We're not doing a great job. So for that, we've seen already, we've seen evolocumab, we've seen evolocumab. This is, during the, remote or recent acute coronary syndrome. But what about, if you look in more detail, you see the sooner you start, the better you get the benefit, mainly in recent MI. These are the sub-analysis of the Fourier and the Odyssey. But if you look at the study which is really focusing on acute coronary syndrome within 24 hours, STEMI, here you want to reach as how soon you will get to the target in LDL. It happens within a few days. It says 8 weeks here, but actually you can tell you a summary here. In patient presenting with acute coronary syndrome, elevated LDL levels in hospital initiation of evolocumab top of in 8 weeks. Achieve your target. Look as much as low as less. So remember that when I said you can reverse the plaque, if you reach that, you certainly reverse the plaque because you have evidence for it. And most of the patient reach that, and it's safe. There's no issues because that study is looking at the safety, not the efficacy, because we already have the efficacy from the other studies. And this is, of course, the study of using a 1 dose once a month of evolocumab, give you the same kind of rapid reduction of on hospital discharge and a 30 days follow-up. So as day 1, reduction has happened as day 1, which is great news. And of course, this is supported by the 2021. It tells you need to use the 3 medication together, of course, and by evidence here, the patient with recurrent acute coronary syndrome, they come back to you again. You have to, think about using these three medication together. And a wealth of studies about the PCSK9, the more higher the cardiovascular disease, the more extreme, the more benefit you get. You need to only treat as low as 16. Imagine, it's like talking a personalized medicine. Just giving an idea about the patient. Look at this 56, all the risk factors. Of course, you need to attack everything: diabetes, dyslipidemia, lifestyle, smoking, everything. But this patient already got heart failure. And look at the medication. Everything you think about it, evidence-based, is there. So, but we have LDL 130. How can you reverse the other lesion like this? Intermediate, this is branches here. These are lesions which will have a plaque rupture in future if you don't deal with it medically, not just only stenting. Be all great in a stent, but that should not be the answer. Maybe the future of even DCB, the balloon. But this need to be lowered by a proper. So in addition to medication prescribing, listen to your patient, guide, support, motivate, involve. That's very important. So we should move away from the high-intensity statin to high-intensity lipid lowering. And this should be three together, especially in somebody with recurrent acute coronary syndrome. So fire and target. Fire and target. And I want to leave you with this. I know I'm finished in advance. So rapid and effective achievement of LDL goal in very high-risk acute coronary syndrome patient available. So earlier and broader use of combination therapy, and I think here really should not waste time if the patient is able to afford it. If the patient, and you think this patient is having recurrent, and you saw all the pictures and you have evidence for it, you should not really waste time. And rapid, effective achievement of LDL in acute coronary syndrome, very high-risk patients, corresponds to treat the target strategy based on the guideline. Intensive and early LDL lowering is the way forward, and easier to apply practice than any algorithm. So what we need to do is, we have a lot of information, a lot of knowledge, and I'm sure, from this meeting we got lots of knowledge there, but what we need to do is just to start to implement it. And thank you very much.